So, thank you. I would like to start a discussion, and of course, I will also ask our organizing office if colleagues who may be listening to us want to ask questions, if they can use the chat. I would say that, involving all the people present here, I believe that the points we must try to stress are various. To begin with, as already emerged from the reports, we already have rather clear ideas about which type of patient we must target for apheresis, but I think some things must still be defined. The other point is the number of sessions, which I think should be adjusted depending a little on the entity and the degree of inflammation of the disease. The third point on which we should dwell are the possible maintenance schedules. So I would like that participants, colleagues, therefore Alessandro, Eduardo, Ambrosio, Antonio too, tell us their points of view briefly on these three matters, which I think... Yes, he's frozen. However, I think Rodolfo, I agree with Rodolfo that these really are three main aspects most relevant to clinical practice for the use of GMA in our therapeutic arsenal for the treatment of IBD patients. Now, with regard to the identification of patients, I believe that this is essential in the sense that doing GMA in a patient who has no inflammation, does not have neutrophils, and has no inflammation cells is unlikely to achieve an appropriate response. It is true that it is not possible to perform a colonoscopy, a rectoscopy, in all the patients we treat if they have already done it a month or 2 months before, but surely those who have active inflammatory activity are the ones that probably are most likely to respond. At the same time, it is true that when there is excessively severe endoscopic activity, an activity that is difficult to control with a standard therapy, granulocyte monocyte apheresis alone is definitely not the ideal therapeutic approach. It must be a combination therapy. But the combination therapy, as demonstrated by previous clinical cases, is definitely better compared to the single treatment. On the other hand, we are shifting towards a combination therapy also with biologics and small molecules. So I don't see why not do a combo therapy with granulocyte monocyte apheresis. With regard to administration, we in Padua essentially perform a cycle of 5 sessions in 5 weeks, followed by a sort of maintenance therapy, a monthly administration, substantially ad libitum, or in any case until we consider it necessary. A little because, as Ambrosio rightly said, it is a therapy that is very much appreciated by patients, in the sense that they ask for it once started. I don't know how to say it. It gives them a feeling of protection, or follow-up, which allows them effectively to feel better psychologically as well. And we, with chronic inflammatory diseases, need this psychosomatic aspect so much as well. In terms of numbers, if 2 weeks, 1 week, maintenance, we do it once a month, but it's not written anywhere that it can be done twice a month. That is objectively a bit of an unknown subject, a grey area in which we act according to our personal experience, the experience of the medical center and availability in the medical center compared to what is present in the literature. Alessandro, from your point of view of, I dare say, a great expert in apheresis, of course, this question is also for the other expert, Irene. What do you think of the matters we have spoken of? What do you say from your point of view? Well, all my experience hinges on the fact that when we manage to modulate the immune response, we get the best effects. In particular, I take cues from all that is the experience with photopheresis. When in rejection, we can control the graft with an immunomodulating therapy such as photopheresis. We get a great result. In terms of patient acceptability, which is the most important thing, so much that I can connect to what you were saying now. It creates the problem of weaning the patient off the therapy. And above all, we have clinical responses that recently have highlighted how it is possible to control even a major infectious disease such as HCV, leaving the immune system competent. Well, we also want to keep organ rejection under control. So I believe immunomodulation is an important road to take in autoimmune diseases, in diseases where the immune system, for some reason, is deregulated. Dr. Tovoni mentioned various apheresis techniques that all have excellent results. And all this is also the result of a strong link between clinicians who are treating that patient, that clinical case. The harmony between experts around the patient also determines the success of the therapy, because calibrating, selecting the therapy well, calibrating it, tailoring it to that patient, is the result of teamwork. And if we aim for this, as we have done so many times, and colleagues Sacco and Tovoni are obvious examples of this, if we proceed this way, we also have clinical results because we succeed in customizing the therapy in the best possible way, choosing from that arsenal of medical procedures described by our colleague Tovoni, choosing the best one. In inflammatory bowel diseases, granulocyte apheresis, because it can be perfectly dosed according to constant clinical evaluation, becomes decisive in obtaining the result. This is my opinion, and it is mostly derived from years of experience with various clinical groups. And with cooperation, when this harmony is created, we have always achieved excellent results. Actually, thank you, Alessandro, for specifying this, because definitely the collaboration, let us say, among experts, and obviously therefore multidisciplinary in this area, is what then leads to clinical success, so to patient welfare, and also the optimal use of the method. I wanted to ask Ambrosio, based on your great experience as an IBD clinician, what are your thoughts on the matters, on the topics we have addressed, and on the 3 points which I pointed out, pardon the pun, as an open discussion on granulocyte monocyte apheresis. What I feel about this technique is that it has been penalized by the fact that ultimately the Shamham trials that Savarino showed us did not give what we could describe as extraordinary results. And this, I think, has discouraged further scientific developments and the use of this technique, which, in my opinion, has huge potential if used well and in specific settings. Stated very briefly, I believe that today, certainly in relation to ulcerative colitis, I speak, of course, of chronic inflammatory bowel disease, because it is what I do, I deal with. Certainly in relation to ulcerative colitis, I think there is sufficient and documented scientific evidence that justifies its use in patients more steroid-dependent than steroid-resistant patients, above all. In this setting of moderate ulcerative colitis, moderate to severe, but also mild to moderate. In other words, mild to moderate to severe, of course, not severe ulcerative colitis, which is setting that must be excluded from this discussion. In my opinion, there are 2 subsets of patients in whom this technique, that, in my opinion, still needs to be well calibrated in the way it is used, in terms of the number of administrations to be done per month, in the first month, and, let's say, from the induction period and in maintenance therapy if needed, which are a kind of bridging therapy in association in patients with moderate to severe ulcerative colitis who started an induction treatment with biological drugs in whom, in some way, it is possible to notice, an expert clinician can understand this, a kind of stuttering, or in a patient who tends not to have a brilliant response during the induction period, and who is still taking steroid doses, which is the reason they have come to have a period of induction treatment with a biological drug. Whatever, I agree with Eduardo, the biological treatment is, including treatment with small molecules today, and of which the only representative we have for now is defactinib. So some sort of bridging therapy in induction to strengthen induction and to avoid, to reduce, those percentages of primary non-response that range between 25% and 30% for anti-TNF-alpha, which are around 20% for other molecules, in particular anti-integrins or anti-interleukins, 12-23. So here, this is a first setting, where, of course, I believe studies should be carried out. This could be an opportunity. I am member of the Educational Committee, no longer in the Society's Scientific Committee, but one of my very close collaborators, Dr. Macaluzzo, is part of the Scientific Committee. We could think of designing a study in this setting. The second setting, I am still talking about ulcerative colitis, is patients who had a primary response and who experience a loss of response, a secondary loss of response, which links to the discussion on immunocomplexes, antibodies. No, you, Rodolfo, showed a special condition where antibodies apparently disappeared after treatment with. Now, this can be a random chance, but it may be in some way also be related and linked to the use of this technique. So this other here is an important setting where you could, as emerged, for example, from my clinical case in a patient who received anti-integrins, not anti-TNF-alpha, in which the immunogenicity, as we know, of anti-integrins and anti-leukins, 12-23, is much less evident compared to anti-TNF-alpha, in particular infliximab, in whom, however, a response to vedolizumab was recovered, and it was possible to suspend steroids, and therefore this technique may favor the recovery of response and the induction of remission in patients who did not achieve remission despite optimizing the treatment with biological drug. So I believe these two subgroups, in my humble opinion, are the most interesting. Once in pre-biologic age, we also use them in patients who received immunosuppressants. We know that immunosuppressants, and in particular thiopurine, have a latency of action that is 17 weeks on average. So if one wants to favor reduction, steroid tapering in that subgroup, if you wanted to treat a steroid-dependent patient with thiopurine as well, you could also include granulocyte monocyte apheresis. We know well that thiopurines, despite being drugs that really helped, in recent years or with the advent of biological drugs, honestly, they seem to be gradually exiting the stage of chronic IBD treatment. So, according to me, these are the two settings. In Crohn's disease, I still sincerely, very honestly, with these, and I end here, with these therapeutic schemes, because it is possible, as you showed, Rodolfo, that in Crohn's disease, considering the multiplurality of the disease, therefore, a more extensive inflammatory process, which involves the full thickness of the wall, we need treatments that are more aggressive than granulocyte monocyte apheresis, with inductions, really, I'm not saying daily, but definitely 2-3 times a week, for a period that I'm not able to define exactly, which I would not know, but here too, perhaps, there is room to propose some studies, also inside of the Scientific Society, which in some way I represent. And then the thing is, thank you very much for this talk, that in clinical terms was truly brilliant. I was saying that the case I presented has also been explanatory of this large collaboration that we established with the colleagues, with Alessandro, with Irene, which surely gave us some experience to continue these discussions. What I pray for, what I am asking you, and my heartfelt request, as an esteemed representative in the IBD group is, and of course I, Eduardo, Alessandro, are all at your service, is to raise awareness of the potential of this therapy, obviously framed in the right way, in the right setting, with the associated possibilities of study among IG-IBD colleagues, because, I tell you, it seems to me sincerely that more than one of them see it as a smokescreen. So, heaven forbid, I am not criticizing, and I am very happy of your presence, precisely because, in the light of your great experience as IG-IBD's leading representative, it may be that perhaps this type of therapy, which is an arrow that we have in the bow of the therapeutic arsenal, this therapy may at least begin to be considered. Similarly to what the Spanish group does, because the Spanish group, which, as you know, is another very active group, in that sense, considers it as one of the therapies in the range of treatments available to us. I also spoke to Cabriada once. It is part of their official therapies, let's put it that way, that they consider as part of the scientific society, such as the Spanish one, which I think is definitely as important as the Italian one. So what can you tell me in this sense? What can you tell us? I will answer right away. I am, of course, aware of, let's say, the opinions of each of the components of the IG-IBD. I could tell you who is in favor, who is not, who is undecided. In other words, I know well what the views are of many of the representatives of our society. This is due to two factors, in my opinion, which, however, can be resolved, so to speak. One is that there has never been clarity regarding the setting in which this technique is to be used, and this must be defined. It must be defined within a precise range, because if not, as occurs for many of our other therapeutic arrows, that our archer has, that is, we must establish the setting clearly, based on the evidence which Eduardo showed, but also that our clinical cases in some way have identified. This is the first point. The second point leading to this reluctance is that, as you know, we unfortunately always refer to the guidelines. We refer to European guidelines. The European guidelines, let's say, that this technique, how can I say, perhaps it has been evaluated and judged, at least until now, a little too severely, in my opinion. That is, in my opinion, there are elements and evidence that may create room to use this technique, and of course, I believe that they are the ones I mentioned to you, that I don't want to repeat, and that, however, should be defined, where this is still not clear, at least there are the foundations to be able to undertake studies, in my opinion, within the society. They cannot be spontaneous, but they must take place in the society where a precise role for the use of this technique in that setting will be stressed. I can speak for you. As you are asking me, I will. Absolutely, but also thanks to you, we can also form a working study group, which can then define the lines to propose in the society and perhaps develop studies. Because you rightly referred to the international situation, but then we know that Dignes, who is one of the people who wrote the guidelines, as you see, he authored plenty of studies on apheresis published in good journals. However, he did not fight when he had to set out the guidelines. Evidently, he did not push enough, or he struggled to find, how shall I put it, a position for this technique within European guidelines. So I accept your invitation. I think it is also an invitation from Eduardo, and I will strive, also from Alessandro Mazzoni, who, let's say, is a pioneer of apheresis in Italy, and therefore, truly, absolutely. I am a member of both the guidelines on ulcerative colitis and on the guidelines for Crohn's disease, which will be published soon in JCC. And I have to admit that when, especially for ulcerative colitis, I raised my hand to say, let us also address the problem of granulocyte-monocyte apheresis, in one of two statements, I received this reply from the ECHO team leaders: there is not enough money for two more statements. So this made me hold my peace now and forever, but, ridiculous answer, it doesn't mean that in the future this cannot be done. I understand that in the structure of the guidelines there is money to spend for statements, PICO, and more. But really, yes, they are answers that, as you rightly said, are worthless, because we need to offer what is evidence, to present the evidence not according to the intended budget, for writing a guideline. Therefore, simply stated, here is scientific evidence. I showed it first, and it is not possible to scotomize all this evidence completely. Ambrosio, however, is right about identifying the setting. We can't say, let's treat everyone, because let's treat everyone brings no benefits. I totally agree. Identifying the setting as accurately as possible also allows us to obtain data that are randomized and controlled in the context of IBD, which can be supported, can be presented, as proof of the fact that in that particular setting, the therapy is extremely effective. So, Ambrosio, I extend this invitation also to be, let's say, a little more active also for the colleagues who are listening to us and whom we would like to thank for taking part. Let us part with the intention of maybe meeting in person to try to understand and set out some kind of catalogue for the work we have to do in order to bring it to the attention of the IBD. Here is a counter-proposal. You, Eduardo, and I design a study, a slim, simple, clear study with accurate outcomes, a precise setting, to be submitted as co-authors to our society. I absolutely agree. So this, let's say we commit to making a call in which we discuss the design of this study, then one of us three writes it, the other two review it to then submit it. There is a very interesting thing, and luckily we have plenty of time to discuss it, and incredibly, we were 25 minutes ahead of schedule, fortunately. This rationale of vedolizumab use, along with leukocytopheresis, I find it an extraordinary thing, because the therapeutic principle of vedolizumab, how shall I say it, embraces the logic of using granulocyte monocyte apheresis. So this technique could, for example, strengthen the treatment with anti-alpha 4 beta 7 integrin that we now know blocks the rolling of anti-inflammatory cells towards the lamina propria of the intestinal walls. So what do you think? There are some case reports, I believe, in the literature. Yes, on this we completely agree. Then let's part with the intent. Sorry, Rodolfo, I mean, the therapeutic approach of combined apheresis techniques and biological drugs, monoclonal antibodies, is something that is already applied in other settings. For example, in Moscovitz, TAMS. Just now, Dr. Devoni and I are carrying out similar work on a particular case of neurological disease. So we can design a study that also includes a combination of this type. There is nothing incompatible, quite the contrary. So let's part with the intent, and then I will hand over to Ambrosio for the conclusion to meet as we have today. I am happy that we have involved in this beautiful discussion the course members to make a call and design a study which we will then submit to the attention of the IBD. I take the opportunity again to thank everyone, and it really was a beautiful afternoon. Thank you all. And thank you, of course, to Innovamedica that gave us the opportunity to discuss. I hand over to Ambrosio. Thank you, Rodolfo. Thank you all. Thanks to Innovamedica that invited us and that has built this very interesting meeting, and which, once again, has led to insisting on a therapeutic strategy that, in my opinion, is used too little, at least in the context of chronic inflammatory bowel diseases, and that I believe, and not just me, but all the people who participated today, according to the scientific evidence which has been shown today by Eduardo Savarino, Professor Savarino, and also mentioned by Rodolfo and myself, deserves a better fate. It is clear that if this is to happen, some things need to be clarified. The first is the clinical context in which this technique, that is not a medication, as I always repeat, and is very welcome and accepted by patients. Very welcome and accepted by patients. And to feel linked to this kind of filter, which in some way, I quote, in their imagination purifies their blood, causes them to be more accepting of it, and psychologically helps them to, how shall I put it, to consider this technique a technique that they like very much. I said the right setting. The right setting, I repeat in my opinion, is currently mainly ulcerative colitis, that is steroid-dependent, more than steroid-resistant, but also steroid-resistant less in association with biotechnological therapies and monoclonal antibodies, anti-TNF-alpha, anti-integrin, anti-interleukin 12-23, but also, why not, small molecules that are appearing now in our therapeutic arsenal, especially anti-JAKs, of which today we have tofacitinib as the only representative, but very soon we will have many others, from filgotinib to upadacitinib and so on, and in patients with particularly severe disease, in whom the induction period of the biotechnological drug can be strengthened, reducing the primary non-response of these patients. The second setting is patients who have developed a primary response to biotechnological drug or small molecules who, however, experience secondary loss of response and so need to resume steroid treatment and then find themselves to be steroid-dependent again, in addition to being dependent on a biotechnological treatment or small molecule treatment. In these patients, this technique may help recover a response to the biotechnological drug or small molecules. So these, in my opinion, are the two settings for chronic inflammatory bowel diseases. We were also shown by Dr. Timoni what important role this technique may have in some autoinflammatory or rheumatological disorders, in particular Behçet's disease. It is a technique that, as Dr. Timoni said himself, often stimulates, from the point of view of, let's say, diagnostic possibilities, a chronic inflammatory bowel disease. It is not a rare occurrence to receive a different diagnosis, in particular Crohn's disease. We know that Behçet's disease can have a bowel localization that is very similar to Crohn's disease, and often the endoscopy lesions are indistinguishable from those of Crohn's disease. So much so that the diagnosis is carried out with other diagnostic media, and sometimes the diagnosis is undefined for long periods of time. Then Dr. Timoni also showed other roles in other rheumatological diseases. Simply stated, there is room to use this technique, it is major. We have significant scientific evidence, and perhaps the precise setting in which it is to be used has to be stressed even more, and especially the timing of administration of the technique. The fact that this has not been done has, in my opinion, been a drawback for this technique, because such a generic use of a therapy without precise indications, without precise treatment protocols, causes clinicians to be wary of that technique. I believe that today our efforts, the commitment we made, I have almost finished, with Professor Savarino and with my colleague Rodolfo is also that, collaborating with people who have great experience in using this technique, we design a study to be submitted to the scientific society, which in some way represents chronic inflammatory bowel diseases, of which I'm a member, at least for the part, let's say, of inflammatory diseases. For the rheumatological disease, I think my rheumatologist colleagues will do the same, maybe in other contexts. This may help to raise awareness among the colleagues who are part of the society, perhaps at last. I am convinced of this, and I say it today, and I hope not to be proven wrong in a few years' time. This technique will be included and will find a place inside the European guidelines, and not only European ones. I do not want to discuss why European opinion leaders did not want to insert leukocyte apheresis. We could think some bad thoughts on the role of American multinationals in relation to the relationships that have been established between some international opinion leaders and some companies that produce biotechnological drugs, but this is not the right context to talk about it. With this, I am ending, and if there is a rheumatologist who wants to say something more than I did it in the rheumatology field, I will hand over to them. Thank you. So, we are now drawing to a close. Thank you all. Thank you all. And let us part with the invitation to meet again to write this study. Thank you all again, and good afternoon. Thank you all. Thanks again. Thank you. To see you all. Thank you. Thank you all. Thanks to Innovamedica.